Dear colleagues, dear friends, and dear Frank, thank you for this opportunity to update you on the branched arch endograft. And I'm going to focus on the latest evolution, which is the total percutaneous aortic. Those are my disclosures. We've published a couple of months ago the global experience with the arch branched endograft in chronic dissections. When I say chronic, I mean patient that had a prior open type A repair. And you can see that in the cohort of 70 patients, we reported an unmatched in-hospital combined mortality and stroke rate of 4% with a very high technical success rate. What we've learned from that experience is that most of those patients with a chronic type A dissections or chronic dissections following an open type A repair can actually be treated with a free branch endograft. We added to the two antegrade branches a retrograde branch with an indwelling catheter. And you can see here after open access to the carotid to position the two bridging limbs, we access the left subclavian artery branch from below from that indwelling catheter. Those are a couple of examples. Now, recently, Emmanuel Tenorio and Gustavo Duric reported the global experience with the free branch endograft. They also came up with very positive early outcomes and also with a high rate of secondary intervention, most of them being because of access complication. And remember that we need open access to both carotid, and those patients have an ACT above 350 throughout the case. So to reduce the risk for secondary interventions, we published recently this new technique, which is a complete percutaneous approach to those free branched endograft. This is how we do it. We do a percutaneous puncture of the right axillary artery, position two proglides. We secure that approach with the right brachial sheath. You can see the access to the groin, femoral and artery and vein, a right brachial artery access, and right axillary access here. And at the end of the procedure, if the proglides don't work perfectly because of the right brachial approach, we can position a short covered stent to get a seal. And to access the left common carotid from the groin, we change the position of the indwelling catheter. It goes out of the left subclavian branch and then inside the endograft lumen again through the left common carotid branch here. And you can see that once a sheath has been advanced over a wire push through the indwelling catheter, a reverse angle catheter can push a 4-meter wire that you can snare from the groin over this through and through wire. You can push a 10 or 12 inch sheath all the way to the ascending and pull it back into the branch. And once you're in this position with a parallel wire and catheter, you can access the left common carotid artery and position your bridging stent. Couple of images from such a procedure under rapid pacing. The endograft is released. We perform those procedures with the GE Discovery hybrid room under fusion guidance. Once the endograft has been released, wire and tip of the delivery system are removed from the left ventricle, here from the axillary axis, getting into the inner branch for the innominate. Here we're looking at the position of the bifurcation of the innominate from the right axillary advancing the bridging limb. That I will soon release here. There we are. And then we shoot a small angio to check that we have a good seal and a patent carotid and right subclavian artery. And you can see that after having closed the proglides here, we open a short B graft to get a perfect seal at the level of the puncture of the right axillary. And then the next step is to get access to the left common carotid. Once you have pushed this 5 French sheath through the two branches, the reverse catheter here, push a wire that you snare from the groin. Here I'm snaring the wire. Now we're getting the large 10 French sheath all the way into the ascending and pulling it back into the the left common carotid. For the sake of time,
next picture.
I'm just going to show you the completion CT scan, and just to tell you that it's now our #1 technique to perform those procedures in patients with chronic dissections.